Everyone, today I'm going to be speaking about recognizing and understanding premenstrual disorders. So to get us started, I'm just going to talk about clinical presentation in PMDs broadly. So here I'm just going to give a quick overview of the cycle. So along the x-axis here, we have time, and on the y-axis, we have these cycling hormones, estradiol and progesterone. So a typical menstrual cycle is about 28 days, and it can be divided into two halves that are bisected by ovulation. So in this picture, you can see that the follicular phase is characterized by increasing estradiol. And then after ovulation, in the luteal phase, we see this peak in progesterone and a secondary peak in estradiol. So estrogen and progesterone then fall precipitously during the perimenstrual time frame, right here at the end. So in 2013, the APA added premenstrual dysphoric disorder, PMDD, to the DSM-5. So PMDD is characterized by at least 5 symptoms that are distressing and impairing in the luteal phase of the menstrual cycle, right? So you can see this clear kind of on-off pattern of symptoms where there are no symptoms during the follicular phase, and then this rise in symptoms during the luteal phase with typically a perimenstrual peak in symptoms. And although this red line represents an average case in terms of timing and severity of symptoms, many people with this disorder have these more severe symptoms throughout the entire luteal phase. So even though here we're seeing them kind of climb and then peak, for a lot of people, they're quite high throughout the entire luteal phase. And it's important to note that PMDD can be comorbid with another disorder, right? So you can have these cyclical fluctuations in symptoms while also having more chronic symptoms associated with another mental health disorder. So here are the 11 symptoms in the DSM-5. So in order to meet diagnostic criteria, the patient must have at least one of the 4 symptoms that are highlighted up top. Following that pattern that I just described, where the symptoms are pretty much off during the follicular phase, or at least minimal, and then really climb and peak during the luteal phase and perimenstrually. And then they can have any other 4 symptoms following that pattern, just to reach a total of 5. In reality, people may have less or more symptoms than that, and that's okay in the context of clinical practice. Treatment is usually useful so long as someone has this pattern where there are significant cyclical changes in distress or impairment across the reproductive cycle. So the important thing here is that you have to have 5 total symptoms, at least one of them being one of those core emotional symptoms. So as a reminder, those are affective lability, irritability and anger or interpersonal conflicts, depressed mood, or anxiety. So you can have one or multiple of those. So you must have 5 total symptoms, at least one being from that top category. You must show distress or impairment, right? This rules out just minor PMS to show that this is really clinically significant. It must be confirmed with daily ratings across 2 cycles, and we'll talk a little bit more about that later. And this can not only be an exacerbation of another disorder's symptoms. So it may co-occur with another psychiatric disorder, but it can't just be an exacerbation of certain symptoms associated with another disorder. And finally, it can't be attributable to the effects of a medical condition such as endometriosis, substance use, or medication use, like contraceptive intolerance, right? We need to be able to see that this is kind of a disorder associated with cyclical changes in your reproductive hormones while naturally cycling, right? It can't just be a response to birth control. So what causes PMDD? PMDD is a suspected hormone sensitivity disorder in the brain. So studies suggest that among women and AFAB individuals with PMDD, the brain circuits involved in their emotional response may activate differently compared to those without PMDD. So in 1998, researchers at the National Institute of Health, the NIH, found that those with PMDD are more sensitive to the normal changes in the sex hormones estrogen and progesterone. And later in 2017, they found that this might actually be due to differences in the genes that process sex hormones. So this just really underscores the idea that this is a very strong biological basis. And there are many ongoing areas of research into the causes of PMDD. Ultimately, it may be that PMDD results from a combination of factors. So I just want to give a quick kind of straightforward case example. So here we have Jenny. Jenny is a 24-year-old female presenting to the gynecologist complaining of intense hopelessness, irritability, and agitation each month before her period that then goes away when her period starts. So she says, I can almost feel it switching off overnight when my period starts. When I wake up one morning, my symptoms are gone and my bleeding has started. I feel like a totally different person, and I have to pick up the pieces from the previous week. So Jenny, this patient, is prescribed luteal phase SSRI treatment, which we'll talk more about, and experiences a nearly complete remission of all symptoms. So she is SSRI responsive with her PMDD symptoms. On the other hand, here is an illustration of premenstrual exacerbation, or PME. So premenstrual exacerbation is another core premenstrual disorder in which the symptoms are present all the time, but they worsen significantly in the luteal phase and in the perimenstrual weeks. So this is actually not an official diagnosis in the DSM, but we hope that within our lifetime, this can become an official DSM specifier so that this disorder can be given different disorders can be given a qualifier. For example, major depressive disorder with premenstrual exacerbation to indicate this PME component, which may need specific treatment beyond just traditional treatments for MDD without that PME specifier. In terms of point prevalence, we know that 60% of ovulating people with major depressive disorder have premenstrual exacerbation of at least one symptom, right? So this is quite common. And although we're focused on premenstrual exacerbation of major depressive disorder here, this can happen in any disorder. And more research is coming out showing that we can see premenstrual exacerbation in obsessive compulsive disorder, in eating disorders, in borderline personality disorder. This really can run the gamut of diagnoses. So here's another case example where we're discussing kind of PME of obsessive compulsive disorder. So Therese is a 34-year-old female who is naturally cycling in the context of using a levonorgestrel intrauterine device, or IUD. Since the IUD does not usually suppress ovulation, but it can thin the uterine lining enough to eliminate menstrual bleeding, she's not experiencing a monthly period, but she's likely still ovulating. She has had a diagnosis of obsessive compulsive disorder, OCD, since she was 15 years old, at which time she was overcome with obsessive thoughts about leaving her belongings behind when she would leave any situation or place. So this historically led to hours of checking behaviors for Therese. She was previously treated for OCD using exposure and response prevention, or ERP, as well as long-term SSRI therapy. And these were effective in treating her OCD symptoms. However, recently she complains of breakthrough symptoms, and her husband has pointed out that these symptoms seem to emerge each month for just 1.5 weeks. She's frustrated that her CBT and SSRI approach is no longer controlling her symptoms. So her therapist encourages her to track her symptoms daily, and a monthly pattern is observed in which her symptoms worsen for 2 weeks, and then she experiences breast pain. And then a few days later, her symptoms return to a moderate but manageable baseline. So she is diagnosed with cyclical exacerbation of OCD, even though she's actually not experiencing menstrual bleeding each month, but she is still ovulating. So feel free to use the chat to communicate about, have you seen any patients with PMDD or PME in your clinical practice? What symptoms were most prominent or noticeable to you? Did it affect your clinical interactions, depending on kind of at which point in the cycle you were meeting? So now I'm going to move into talking about the importance of detecting premenstrual disorders. So first, in a large global survey, patients with PMDD, we had a sample of 591 patients, reported seeing an average of 6.13 providers across an average of 12 years before receiving their diagnosis. This is really frustrating and sad to hear, right? That people went years and years and through many, many providers before finding out what exactly was going on and understanding this premenstrual pattern in their symptoms. We often hear from patients that they're getting shuffled around between a lot of different providers, right? They go to their general physician who refers them to a gynecologist who says, I don't know, and refers them to a psychiatrist. And people often get kind of shuffled through many, many providers over many, many years until a provider who is knowledgeable about PMDD can kind of accurately hone in on what might be going on here and assess adequately to provide a PMDD or PME diagnosis. So I also want to note that detection of premenstrual disorders is important for suicide prevention. We know from clinical observation and patient perspectives that over a long period of time, people have been sharing that there are likely high rates of premenstrual suicidality in PMDD, despite cyclical remission. So there's a common possible misunderstanding that because PMDD remits for roughly half of the menstrual cycle, that makes it inherently less severe or less impactful on overall functioning and severity of symptoms. When in fact, we're finding that's really not the case, right? People with PMDD often experience very high rates of suicidality, even comparable or higher compared to many other mental health diagnoses. And a recent global study of those with prospectively diagnosed PMDD, so that means based on 2 months of daily ratings, that recent global study suggested that there are very high rates of suicidality among those with PMDD that are not attributable to comorbid mental health conditions. When you're just isolating out the people who only have PMDD. So if we take a look at this bar chart here, we can see that we've got the black line is people who, everyone in the sample, right? Everyone in the sample had PMDD. Then we've got this red line, which is people with PMDD plus another psychiatric comorbidity. And then we've got this gray line, which is people who only had PMDD. And although people who had a psychiatric comorbidity did have even further increased suicide risk, right? We also saw that people with PMDD alone and no psychiatric comorbidity, that gray line, still have really marked suicidality, right? We see very high rates of suicidal ideation, right? About over 78% of the sample, going all the way to hospitalization. We're seeing kind of high rates of ideation, planning, intent, preparation, attempt, non-suicidal self-injury, and hospitalization, regardless of comorbidity. So now let's discuss some of the evidence-based assessment practices for premenstrual disorders. So one thing we're pretty sure about at this point is that studying premenstrual disorders really does require daily ratings. So across many different studies, we've seen that single time point measures of premenstrual symptoms do not consistently predict an actual pattern of premenstrual changes when people complete daily ratings. So cross-sectional self-reports and interviews for PMDD show good sensitivity, so few false negatives, right? If someone reports it, but very poor specificity, many false positives. In fact, we find that these things only agree at about 30%. Only about 30% of people who report that single time point retrospective memory of PMDD symptoms actually end up having PMDD when they complete the daily ratings over 2 months. So because of this kind of accumulating research, the DSM-5 actually requires tracking daily symptoms across 2 cycles in order to be diagnosed with PMDD. So it's really just not possible to do good cycle science around premenstrual disorders using a single time point questionnaire. And this is frustrating and requires a lot more work and a lot more time, but it also means that cycle scientists end up with some of the coolest data, right? Because we are forced to use these daily ratings and then really be able to look at these kind of granular differences day to day. So with all that in mind, from a clinical perspective, screening instruments such as the premenstrual symptom screening tool, the PSST, can be used when daily ratings are impractical, but often that's really just a first step to kind of figure out if it's worth then assessing for daily ratings over time. So if someone endorses symptoms on the PSST or some other clinical interview, that's an indicative that they should start daily ratings. So important steps in diagnosis. First, there's this universal screening question, right? Do your symptoms change across your cycle? If a patient says yes or is unsure, it's worth using that premenstrual symptom screening tool, that PSST, to screen. If the PSST is suggestive of moderate to severe changes, then it makes sense to have the patient begin daily tracking. They'll complete 2 cycles of daily ratings, and then the practitioner, the clinician, will review that data. There are automated collection and scoring tools in development. One gold standard in research is the CPAS. But in the meantime, in clinical practice, visual inspection for a PMDD pattern is fairly standard, right? Just being able to see that there seems to be this kind of high severity, high duration peak in that luteal phase of the cycle, and then this kind of remission of symptoms once you get to a day or two after menstrual bleeding starts. So as a reminder, PMDD is applicable if 5 or more symptoms are moderate to severe in the luteal phase and then remit to minimal or absent by the end of menses. PME, on the other hand, premenstrual exacerbation, is applicable if chronic symptoms become worse before or during menses. One other important thing to note is that some individuals will not report cyclical changes despite having them. So keep in mind the possibility of tracking the cycle alongside mood and other factors like sleep if you suspect a cyclical component, even if the patient denies a change. I know I've worked with people where I felt like for 1 week each month, sometimes 2, I felt like I was seeing a different person, far more irritable, far more angry, right? Far more overwhelmed. So we begin daily tracking, and we can then kind of illuminate what might be going on cyclically. So this is just a little more information about that premenstrual symptom screening tool, the PSST. I've got a citation down here for that as well, but this is just kind of some of the things that we are assessing. We're assessing all of those core symptoms, right? We're understanding on a scale from not at all to severe, how angry or irritable are they during that premenstrual time, how anxious, etc. It also assesses kind of impairment, right? Have your symptoms interfered with work efficiency, with relationships with coworkers, relationships with family, social life activities, home responsibilities. And remember, this is critical because it's not PMDD if there's no distress or impairment, right? The distress and impairment are critical for making that diagnosis. So being able to get this broad lay of the land with something like the PSST cross-sectionally, just based on one time point, it can kind of clue you into whether it's worthwhile to start doing daily ratings with someone. Then we get to the task of gathering daily ratings for a PMD diagnosis. So the gold standard here is the daily record of severity of problems, the DRSP. So this includes 24 items, all 11 of the DSM-5 PMDD symptom domains, as well as some impairment symptoms, and they're all rated daily on a scale from 1, which is minimal or absent, to 6, which is extreme. If you'd like, you can check out the IAPMD website /symptom tracker, and we include free printable versions and a guide to tracking symptoms there. So you can refer patients to that resource. There are also some great smartphone apps that use the DRSP. So here I've listed Prementrix. Another great one is Me versus PMDD. Those are kind of two great apps for tracking symptoms daily. Some nice features of those smartphone apps is that it prevents backfilling, right? Someone can't write down their ratings from the past week today, right? Because it really is trying to understand what is the prospective report? What is your experience today, rather than counting on you to remember your experience 5 days ago? Because then we just run into the same problems that we have with those retrospective self-report measures. The other thing that's great about these apps is that you can add symptoms, which is especially good for evaluating PME. For example, let's say someone has OCD, right? And we want to add an item about checking behaviors to understand, are those checking behaviors changing across the cycle? Or PTSD, do we want to understand if people are having more nightmares across the cycle? Other nice features of the app is it reminds people to rate their symptoms each day, and it produces a graph of the symptoms relative to menses when they started their menstrual bleeding. It can track treatment effects, right? You can include kind of what medical treatments you're taking at a given time. And your prementrix graphs can be printed or sent to the provider, and then the provider can go ahead and score and take a look kind of through visual inspection or something kind of more intensive with scoring using something like the CPAS to understand the pattern of symptoms, potentially make a diagnosis. So here's just an example of the symptom graph that Prementrix will kind of spit out for you. So you can see here, let's say this is anger symptoms, right? And you can see that this is someone who is showing this clear kind of premenstrual worsening, kind of following this PMDD pattern, where we're seeing that they have kind of moderately severe all the way to very severe anger kind of across. We're seeing 4s, we're seeing 6s, we're seeing 5s during that luteal phase, right? And then when they start menstrual bleeding, there's kind of this immediate drop off. Maybe there's another kind of spike back up to 4 within the first few days of menses. But then by the time they've finished menstrual bleeding, we can see that the symptoms are really minimal compared to where they were premenstrually. Right? So it's got this clear symptoms on pattern in the luteal phase, symptoms off pattern in the follicular phase. So if you're a clinician and you're looking at something like this, you can say, well, the anger profile is suggestive of PMDD, and you can see it for each symptom to understand what's going on. So here's another case example to illustrate the importance of daily ratings. So Kiki is a 28-year-old female referred for dialectical behavior therapy, DBT, for a diagnosis of borderline personality disorder. She experiences extreme mood swings, suicidality, dissociation, and splitting in her intimate relationships, along with episodes of rage and throwing objects at her family. Her mother accompanies her to the visit and notes that she always struggles with depression and irritability, but sometimes it just seems to go off the rails for no apparent reason. So Kiki joins your DBT skills group and participates well most weeks, but occasionally she has weeks where she's withdrawn and irritable and she doesn't engage. So 1 month in the emotion regulation module in group, when she's tracking her ABC please skills, right, which are all about kind of protecting yourself and protecting your emotional vulnerability by taking care of yourself physically, she recognizes that there is a week in which her body and mind felt completely out of control and vulnerable. She rates this as a 10 out of 10 severity, which then resolved to more manageable baseline levels, more like a 5 out of 10 in terms of severity, about 5 days into her period. So after her psychiatrist reviews her daily ratings from the DBT diary card, she is diagnosed with premenstrual exacerbation, PME, of borderline personality disorder. And she starts to trial PMDD treatments to treat this premenstrual exacerbation. So feel free to write in the chat again here, what concerns do you have about using daily ratings to diagnose cyclical patterns in clinical practice? Next, I'm going to provide a brief overview on the biology of premenstrual disorders. So, the key here is that PMDD is an abnormal sensitivity to normal hormone changes across the cycle, right? So there are studies that have focused on understanding which hormonal triggers are associated with changes in psychiatric symptoms. So there's one experimental study that had two groups. They had PMDD participants and they had control participants. And at baseline, you can see the PMDD group has psychiatric symptoms showing up in the luteal phase. That's this black line here. And you can see that the controls do not, right? They do not have an increase in luteal phase symptoms. Next, the researchers gave everyone a GnRH analog called leuprolide, which induces a temporary chemical menopause, which creates this low, flat hormonal state. So when the hormones were kept at this low, flat state, the PMDD group no longer showed symptoms. However, when the hormones were added back in the luteal phase, when the hormones were added back to luteal phase levels, I should say, you can see that the PMDD group then spiked up again in their symptoms, right? So their symptoms kind of remitted when temporary chemical menopause was induced and they had this low hormonal state. But then the symptoms climbed back up when they were given a hormone add back that mimicked kind of luteal phase levels. Once again, the control group did not have that experience, right? When they were given this increase in hormones to mimic luteal phase levels, they still didn't have emotional symptoms in response. So there's evidence here for a differential sensitivity to these normal hormone changes, right? So we know that it's this abnormal sensitivity to normal hormonal changes. Then we have this other study where they repeated the whole thing. And then at the end, they left patients on the hormone add back for an additional 2 months. And what they found was that after the first month of the symptoms returning, the symptoms went back down to baseline in the second and third months of add back, despite hormone levels being the same, right? So when they first gave that add back, the symptoms surged up. But when they kept that add back level stable over months 2 and 3, the symptoms remitted again. Meanwhile, the controls, nothing's going on with the controls. This suggests that people with PMDD are having an abnormal response to normal changes rather than being sensitive to hormones at a particular level, right? Because when the level was kept constant, the emotional symptoms still remitted in months 2 and 3, right? It's the fact that there weren't changes in the levels anymore that protected people. So it's really important to educate patients about these biological causes, right? It's important for people to understand that premenstrual mental health changes are caused by an abnormal brain sensitivity to the normal estrogen and progesterone flux across the cycle. In many studies, no hormonal or gynecologic abnormalities have been found. Levels and patterns of hormones are normal, and no blood test can detect it. But let's talk a little about what we know about the pathophysiology of PMDD. There are several ongoing lines of research into causes, right? Such as abnormal GABA A receptor responses to these normal hormone fluctuations, or abnormal reductions in serotonin during normal hormone flux, right? This is a big one. We know that there is an abnormal cyclical change in the serotonergic system for those with PMDD. There's also differences in the expression of hormone responsive genes. There are probably many different causes that may differ between patients, both at the biological level and potentially at the environmental level as well. So now we're going to talk a bit about evidence-based treatment for premenstrual disorders. Okay. So let's start by talking about SSRIs and SNRIs. So this is the frontline treatment for PMDD. What we know is that it can be taken on various schedules, right? You can take the SSRI or SNRI continuously across the whole cycle, right? This is probably most effective for people who do have symptoms all the time that just worsen significantly during the luteal phase, right? If there's someone who it's more of a PME pattern, for example, or there's another mental health diagnosis that's also being treated with the SSRI, we want to make sure we're not under-treating someone by only using luteal or symptom onset dosing. So for someone like that, continuous dosing would be most appropriate. But many people prefer a luteal phase dosing regimen. This is good because it's less expensive and just requires not taking it the entire month. For luteal phase dosing, we think this is likely most effective for someone who has kind of this pure PMDD presentation, maybe doesn't have a comorbidity that would also be responsive to an SSRI, right? So they would only take it during that luteal phase of the cycle and then stop within a few days of menstrual bleeding. Still for others, others might try symptom onset dosing. So this would be kind of intermittent therapy beginning at the point of symptom onset until the first few days of menses. This has also been shown to be effective. So this is another option. There have been quite a few randomized control trials showing the following SSRIs to be effective. You'll see here fluoxetine at 20 milligrams, sertraline, paroxetine, citalopram, and escitalopram. So how does it work? SSRIs work by normalizing altered premenstrual serotonin levels and altering metabolism of hormones to normal steroids. And what's striking in RCTs is that SSRIs tend to beat placebo within 24 hours of beginning to take them. So who does this benefit? We know that SSRI treatment works well for PMDD and for PME, and it works rapidly in the first cycle. In terms of efficacy, there's a 70% response rate, so that's quite good. SSRIs really have the strongest high quality evidence. There are numerous positive RCTs in PMDD looking at each of these different dosing schedules, continuous, luteal only, symptom onset. And there are also a few positive RCTs for premenstrual exacerbation. This typically involves taking the SSRI continuously, but then increasing the dose during the luteal phase. In terms of side effects and safety, SSRIs are generally well tolerated with generally mild side effects. The most common side effect that leads to discontinuation is sexual dysfunction. So it's really just about kind of weighing those pros and cons with your patients based on their response. Another treatment option is behavioral therapy for symptom management. So cognitive behavioral therapy, CBT, has been tested, and dialectical behavioral therapy, DBT, although there are no clinical trials at this point, it's also reasonable when suicidality or emotion-related impulsivity is present in the context of PMDD or PME. So how does it work? With these behavioral interventions, this is about reducing symptom severity, but not cyclicity, right? Because we're not treating the kind of biological basis there. This does reduce impairment, right? It's helping people figure out how to cope with these symptoms and make them more workable. It can also improve relationships with doctors and providers, right? Because it can make you more effective in those interactions. Once again, it's about kind of figuring out how to work with these symptoms, how to cope with these symptoms, even if we can't actually change the cyclicity. In terms of who benefits, we know that people with PMDD can benefit from CBT. Chronic mental health conditions with premenstrual exacerbation are also likely to benefit. There just isn't a lot of clinical trial data out there around this yet. In terms of efficacy, 2 clinical trials show that CBT does have a benefit for improving the severity and impairment of symptoms. And DBT is beneficial for suicide prevention in cases in which interpersonal conflict is high. So it makes sense that this would be well suited to treating PMDD as well, given that suicidality and interpersonal conflict are such pronounced features for many with PMDD. What's great about behavioral therapy is that extremely safe, no side effects. And for a lot of people, it's what they're looking for, right? A lot of times it's about meeting people where they are. People want a way to kind of behaviorally manage these symptoms. So here's another case example to illustrate the unique benefits of SSRIs in PMDD. So Tanya is a 32-year-old female presenting to a gynecologist complaining of severe PMS that hasn't responded to antidepressants. She also experiences chronic pain. She notes that she's frustrated with her psychiatrist because she keeps trying to use antidepressants as a Band-Aid when the real problem is her hormones. She reports that she is seeking a hysterectomy and bilateral oophorectomy for her symptoms, which is an evidence-based but extreme option. The gynecologist asks her psychiatrist colleague to evaluate the patient to ensure that all pharmacologic avenues have been exhausted. Upon interview, the psychiatrist discovers that the patient takes dazipramine to control her chronic pain, but that it does nothing for her PMS. She's also tried bupropion, which also did nothing for her cyclical symptoms. So the psychiatrist explains that PMS and PMDD generally require a serotonergic treatment. So the patient agrees to try an SSRI, right? The patient experiences a large reduction in symptoms and thanks her gynecologist for referring her for an evaluation before proceeding with major surgery. Okay. Oral contraceptives are another effective treatment, particularly drospirenone-containing oral contraceptives. So we know that the randomized clinical trials show that the drospirenone, 3 milligrams of drospirenone with 20 micrograms of estrogen on a 24/4 schedule is the effective dose in treating PMDD. We have positive RCT evidence for that dose. So this is something like Yaz birth control. How does it work? It suppresses ovulation and related hormone flux. So oral contraceptive pills in general, they are suppressing ovulation. And if PMDD is a disorder of ovulation because of the normal changes in estrogen and progesterone that occur as a result of ovulation, this is an effective way to kind of treat PMDD by suppressing that ovulation. So who benefits? Well, we know that this is that RCT evidence shows that this is beneficial for PMDD. In terms of PME, we don't know across a broad range of disorders. We do know from a 2018 study that birth control is not, that specifically drospirenone-containing birth control is not an effective treatment for PME of depression, right? So we're seeing it's likely that PME of depression has a different pathophysiology than PMDD on its own. And we're seeing that a lot of the treatments that are effective for PMDD are not effective for PME of depression. This doesn't mean that they wouldn't be effective for PME of another disorder. We don't know yet. In terms of efficacy, there's moderate quality evidence for birth control. There are several trials. But meta-analysis draws size of effects into question. The effect sizes might be small. In terms of side effects and safety, people can experience nausea, intermenstrual bleeding, breast pain, and especially with drospirenone-containing oral contraceptives, there's a higher rate of VTE than other oral contraceptives, which also means there needs to be kind of careful consideration for clotting risk factors before prescribing something like Yaz. So another case example here, treating PME of OCD. So we talked about Therese before. She's a 34-year-old female who's naturally cycling in the context of using a levonorgestrel IUD. Since the IUD does not usually suppress ovulation, but it can thin the uterine lining enough to eliminate bleeding, she's not experiencing a monthly period. She's had that OCD diagnosis since she was 15, and at which time she was overcome with obsessive thoughts about leaving her belongings behind in any situation. She engaged in lots of checking behaviors. She did ERP and SSRI therapy, which was effective, But then she started to have these breakthrough symptoms that were occurring for about 1.5 weeks each month. So she started to notice that her CBT SSRI approach wasn't controlling her symptoms adequately anymore. Right? So her therapist encouraged her to track her symptoms, observe this monthly pattern where the symptoms worsened for 2 months, and that then she would experience breast pain. And then a few days later, the symptoms would kind of remit to baseline, return to baseline. She was diagnosed with PME of OCD. She was then referred back to her gynecologist to consider switching her birth control to Yaz, a combination oral contraceptive shown to help with premenstrual symptoms, in part by suppressing ovulation. After some resurgence of symptoms in the first month of Yaz, her symptoms did remit and remained controlled afterwards. So Yaz was an effective treatment for her PME of OCD. Another, this is kind of the next line of treatment, right? If someone seems to have kind of treatment-resistant PMDD that is not responsive to SSRIs and is not responsive to birth control, then we start thinking about something like the GnRH analog treatment with a stable hormone add-back. So GnRH agonist plus hormone replacement therapy, it typically involves leuprolide at a 3.75 dose with a monthly injection. Plus, you'll also do a hormone add back. So this is typically like 0.05 to 1 milligram a day of transdermal estradiol, it can be a pill, or plus continuous micronized progesterone, anywhere from 100 to 400 milligrams. So how does this work? This works by suppressing ovulation and related hormone flux. In terms of who benefits, we know that PMDD that is not helped by SSRIs or oral contraceptives typically responds very well to this treatment. It beats placebo in many randomized control trials and also in a meta-analysis. It's a highly effective treatment for PMDD. Unfortunately, just like we saw with birth control, this treatment is not indicated for PME of depression. We're not seeing that it's as effective of a treatment in that case. Once again, suggesting that there's something different about the pathophysiology of premenstrual exacerbation of depression specifically. In terms of side effects and safety, the important thing to note here is that it requires hormone replacement to prevent menopausal symptoms and risks. So the add back does cause resurgence of symptoms in the first month only, just like we saw in that experimental study to kind of suss out if PMDD is a response to hormone changes or hormone levels. And what we see is that increase in symptoms does kind of remit and go back to baseline or normal after a few months of adjustment. And that the hormone replacement is essential to mitigate risks. This also can provide evidence for the patient and the provider about the likely effectiveness of surgical menopause in the future. If they respond well to this, they'll likely respond well to surgery. So like I mentioned, there can be this temporary resurgence in symptoms with the initial hormone add back. So in that first month, you'll see here that those symptoms do kind of return, but then they remit over time after that first month of stable add back. So this is extra support. So they often need extra support during that first month of add back, right? Extra therapeutic support potentially, which brings me to this next slide about collaborative care during GnRHA plus add back. So in this case example, Miranda is a 21-year-old woman presenting with complaints of severe premenstrual mood swings, irritability, anxiety and panic, overwhelm, suicidality, and binge eating. After her therapist asked her to track her symptoms, there was this clear on-off pattern for each of these symptoms, and the therapist diagnosed her with PMDD and referred her to a psychiatrist to trial SSRIs. Several SSRIs and PRN medications failed, and a trial of Yaz with her gynecologist also failed. So the patient has attended a DBT group for several years, and while she does find the skills helpful, she continues to be severely impacted by her symptoms and is unable to hold a job or keep a relationship. The patient is hospitalized 2 months in a row with severe suicidality resolving upon menstruation. So the inpatient psychiatrist discusses this case with the therapist, and they agree to approach a gynecologist colleague about GnRHA therapy with stable add back. The therapist agrees to see the patient twice per week during the GnRHA process. The patient experiences remission during GnRHA, but the symptoms come back severely in the first 3 weeks of ADVAC, and she's hospitalized again during the 3rd week after disclosing plans for a suicide attempt to her therapist. So the question is, has the GnRHA plus ADVAC treatment failed if there was this resurgence in symptoms after 3 weeks that resulted in hospitalization? The answer is no. The treatment has probably not failed. She is simply experiencing that temporary resurgence phase that we discussed during the initial hormone ADVAC, during which many patients want to end the treatment or end the ADVAC due to this temporary symptom flare. But what's going to happen 1 month later is that the patient reports no symptoms and continues this stable treatment, the monthly GnRHA injection, plus the estrogen and progesterone ADVAC until she reaches menopause for however many years. She continues to check in with the therapist monthly, but reports stable, positive mood with only situational distress, with occasional passive suicidal ideation. Right? So we see that over time, as the patient adjusts to this stable hormone ADVAC, that they do experience a remission in PMDD symptoms for the most part. And that this is safe long-term. They can do this for many years. And this brings us to kind of the next and final option. So a total hysterectomy with bilateral salpingo oophorectomy. This is surgical menopause. So removal of both ovaries is required, and the hysterectomy eliminates the need for progestin ADVAC post-op. And the ADVAC of estrogen only can be tailored to the patient. So how does this work? This is a complete cessation of ovarian activity and related hormone flux. This is beneficial for PMDD or PME that responds to the GnRH agonist trial. So even though we know PME of depression doesn't respond very well to the GnRHA, other forms of PME may, if they trial the GnRHA and it works really well, they're a good candidate for the surgery. In terms of efficacy, this is highly effective for those who benefit from GnRH agonist from that treatment, but who cannot tolerate the stable ADVAC of estrogen and progesterone after at least 6 months of trial. The important things here is that the surgical menopause is only considered after someone has completed the 2 months of daily ratings and has shown a PMDD pattern over 2 cycles, and that they've tried GnRH and that has provided evidence, like that worked and has provided evidence that the surgery can be curative for them. In terms of side effects and safety, there are routine surgical risks. There's risk increases with other medical conditions. This is permanent, right? You can't go back once you've had this surgery. And it requires hormone replacement to prevent menopausal symptoms like bone loss, cognitive changes, and heart disease. So just to summarize all of the evidence-based treatments that we discussed for premenstrual disorders, we discussed SSRIs, either during the luteal phase only or during the full cycle. For PME, you would just increase the dose during the luteal phase. Oral contraceptives, specifically with drospirenone-containing oral contraceptives. Some patients can experience progestin-induced mood disorder. So for some patients, oral contraceptives can actually exacerbate symptoms. It really depends on the person. We know that CBT, psychotherapy for reducing symptom severity and impairment, is effective, along with DBT for suicidality. Pharmacotherapy focused on symptom management is also common at this stage, right? There's some clinical trial evidence for quetiapine, the alprazolam, things like that. GnRH agonist plus stable estrogen and progesterone ADVAC. So this is that chemical menopause plus hormone ADVAC. We know that symptoms recur 1 cycle after the stable ADVAC, but that they do remit if someone has a positive response. And then, of course, if the chemical menopause cannot be continued because of a sensitivity to the hormone ADVAC or what have you, then we start to consider surgical menopause. So that's removal of the ovaries and likely a hysterectomy as well, with an estrogen-only ADVAC. Some possible barriers to good care. First, PMDD is a DSM-5 mental health disorder characterized by an abnormal sensitivity of the brain to normal hormone changes. It was also recently added to the ICD-11 as an international diagnosis. This brain hormone interface often confuses providers in terms of which provider should even be treating it. Uh, we hear frequently reported provider failures among patient advocates. There's a general lack of awareness of this condition. There's also a belief among many that PMDD is a social construction or that it's sexist. It's often misdiagnosed, or another diagnosis kind of overshadows the cyclical pattern of symptoms, even though recognizing and assessing that cyclical pattern may be essential to finding an adequate treatment. There's often minimizing or inappropriate normalizing of PMDD symptoms as just part of being a female, right? There's this lack of understanding that this is a truly distressing and impairing and at times life-threatening diagnosis for those for the minority of people who experience it. And like I alluded to before, there's often these referrals back and forth between therapists and psychiatry and gynecology, which can be a major source of frustration and despair among patients. So by now it should be clear that collaborative care for PMDD is really critical. So feel free to use the chat to discuss kind of what barriers do you anticipate in implementing collaborative care for PMDD? In planning for collaborative care, take a minute and list 3 people who you might collaborate with to care for patients with PMDD. Mention this talk to them and ask if they're aware of the condition and would be willing to collaborate on cases. So we have gynecology. Gynecology, they can prescribe oral contraceptives like Yaz. They can also administer the GnRHA plus stable hormone add back. We have psychiatry. Psychiatry is going to be responsible for the SSRI prescription and other symptom-focused treatments, possibly PRN medications. Reproductive psychiatry, they can prescribe the oral contraceptives, and they can also administer the GnRHA plus add back. And then finally, psychology and therapy. They can provide CBT, they can kind of enhance a patient's coping skills, they can provide evidence-based assessment, and in some cases, like in my clinic, we can also provide kind of consultation on how to navigate the process with some of these other providers. That's everything I have for you today. Thank you so much. It was great time talking with all of you.